All right, class, welcome to the lecture on the axial skeleton and core. This lecture particularly will conclude the trunk and core module for the semester. So within our spinal cord, we have 33 vertebrae. 24 of those is what we categorize as free moving or articulating vertebrae. And 9 of those vertebrae will be fused. That'll be located more so at the posterior region of the spinal cord. Within our articulating region, we have 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. And for our fused region, we will have 5 fused vertebrae in our sacral compartment and around 3 to 5 in our coccyx. For the purpose of this lecture, we will be focused primarily on the 24 articulating vertebra region, which will include our cervical, our thoracic, and our lumbar compartments. Each of these compartments will have a specific curvature, and the curves of the spine allows us to maintain posture and dissipate forces throughout our spinal column. So throughout the different regions of the spine, we'll have different curve components. So for our cervical region, you'll notice that we have a slight anterior or lordotic curve. For our thoracic region, we have a slight posterior curve. And for our lumbar region, we will have a more pronounced anterior or lordotic curve. Anterior and posterior curvature nomenclature can also be substituted for either a lordotic, which is an anterior curve, or a curve that is kyphotic, or a posterior curve. These names are also used to characterize the abnormalities of the curvatures that we see about the spine. So spine kyphosis will be the excessive posterior curvature of the thoracic portion of the spine. And you'll also see this characterized as more of a hunchback appearance. For our cervical and our lumbar regions, excessive anterior curvatures would be called lordosis. And we can also see this excessive lateral curvature, which is named scoliosis. So scoliosis typically occurs in the thoracic spine, and it could be broken down into how the scoliosis can manifest. So for our structural scoliosis, this is an abnormality seen within the actual spine. For functional scoliosis, this would be more postural or muscle imbalances that allow you to compensate whenever you rotate the spine. And for pseudoscoliosis, this would be the unilateral overdevelopment that may initially look like scoliosis, but it's only implicating those muscle imbalances. And we see this a lot, especially in overhead sports and poor synergistic relationships between the scapulothoracic muscles and the anterior thoracic and shoulder muscles. So our vertebra is named for the corresponding region and is numbered from top to bottom. Our first 7 vertebrae will be part of our cervical region. The next 12 vertebrae will be part of the thoracic region. And the next 5 will be part of the lumbar region. So usually how it goes, the first 7 vertebrae will be in the cervical region. So we'll have this C, and then you count from 1 all the way to 7. Once you reach the thoracic region, that C will be replaced by a T. The numerical numbering will start all over, and then you'll go all the way down to the 12th vertebra in the thoracic region. And same line of thought goes whenever we name the vertebra of our lumbar region. Each of these vertebrae is divided by intervertebral discs, in which we'll touch on here in a moment. And they're able to articulate or glide with each other through our synovial facet joints. And whenever we speak about the movements about the spinal column, one individual vertebrae doesn't really move too much. However, the accumulation of each of those vertebrae articulating is what gives us the range of motion we see about our spine region. Each of these regions has a unique structure based on their function, movement, and surrounding anatomy. And we will get into that starting with our first two cervical vertebrae. Now, we talked about this more in depth in the head and neck lecture, but as a review, our first two cervical vertebrae have special names. Our first cervical vertebra, or our first vertebra in general, will be our atlas, and our second vertebra will be our axis. The atlas vertebra is where head flexion and extension occurs, and our axis vertebra is where head and neck rotation occurs. Now, if you all would pay close attention to the particular vertebra, this would be your atlas, this would be our axis, and compare it to the remaining vertebra that we see from levels C3 all the way down to L5. So in our vertebra C3 to L5, you'll notice that we have particular bony characteristics that are similar within these vertebrae. This would include a vertebral body, and this is just the anterior bony block. You'll see this huge opening here. This will be our central vertebral foramen. This is where our spinal cord comes through. And within the central vertebral foramen, you notice that we have these arches on the posterior and the lateral side. Those has names as well. The posterior arch will be our lamina, and the lateral arches will be our peduncles. This is very important, especially when we go into intervertebral discs, as this is the site that is mostly considered for removal whenever we have some sort of disc issue or nerves that are impinged by a bulging disc. Again, I'll touch on that in a moment. Other similar bony characteristics that we have is various processes that protrude out both laterally and posteriorly. The processes that protrude out laterally will be our transverse processes, and we have our spinous processes that protrude posteriorly. So whenever we bend down and touch our toes, those are the bony humps that we feel on our back. So if I were to go back to our first two cervical vertebrae, you notice that we have some of those bony characteristics. Notice that for C1, we essentially have no body whatsoever, or dens. We just have this anterior arch. And this makes sense because this is the region where we flex and extend our head. So having a body on the anterior side may impede our ability to flex our head. You notice on the axis, we begin to have some formation of a body. The official name of that would be our dens, but in both vertebrae, we'll still have our transverse processes, our central vertebral foramen, and the beginnings of our spinous processes. You would also notice as we go from our cervical region to our lumbar region, these pictures are showing the superior and lateral aspects of our cervical, our thoracic, and our lumbar vertebra. You'll notice that these vertebrae will begin to increase in cross-sectional area. And this will make sense because as we go down the spinal cord, more weight or more of our weight needs to be supported. So that's why you'll see the vertebral bodies in our cervical region relatively smaller compared to that of our lumbar region. Staying on these pictures a little longer, our intervertebral joints, and more specifically our discs, will sit on each aspect of our anterior bony blocks in each of our vertebral regions. And you'll also notice that we have the inferior and anterior articular facet surfaces. These are where our facet joints are located, and it's almost like Legos. They will connect together. These are the main sites where movement about our spinal column is realized. Another important region here is we have our intervertebral foramen. Don't get this confused with our central vertebral foramen, because this foramen is where the spinal cord comes from. And our intervertebral foramen is where our spinal nerves come from. So right here on this lateral view, we'll have our spinal cord coming up, and protruding out laterally from the spinal cord is our anterior and posterior spinal nerve rootlets. And these rootlets will essentially come together and form a spinal nerve, which will come out through the intervertebral foramen. And I'm saying all this because there's one structure that is very close to these nerve roots, and this will be our intervertebral discs. Now, these discs play a important role in absorbing the shock that is realized about the spinal region, especially when we ambulate and move around and engage in high traumatic movements. And it's comprised in a way to allow for that dynamic support. So on the outer covering of the disc, we have our annulus fibrosus, and this is mainly made through fibrocartilage. And the inner portion will be our nucleus pulposus. A common analogy that you'll hear is a jelly-filled donut. So you have this more dense outer covering, which allows for the nucleus pulposus to dynamically dissipate forces that's realized about the spinal cord. This image is also good here because you begin to see the superior aspect of the spinal cord, and then you have your anterior and posterior spinal nerve rootlets, which come together to form the spinal nerves, which exit the vertebral body via the intervertebral foramen. So a very common injury or mechanism within the intervertebral discs is when the nucleus pulposus may begin to protrude out and begin to put pressure on the spinal nerves. And this usually occurs through either excessive loading, excessive extension of the spine. I'm actually going to play this again. And what happens is the nucleus pulposus essentially protrudes away from the outer layer, our annulus fibrosus, and the pulposus begins to apply pressure on the spinal nerves. Now, remember the particular components that I mentioned earlier. Within the central vertebral foramen, we have our lamina and we have our pedicule. So whenever there's a situation where we have a slipped disc or a bulging disc, depending on the severity of the bulge, surgeons may come in and perform a laminectomy. A laminectomy is simply the removal of a portion of the lamina. And the idea behind this is in order to decompress the nerve that is being impinged, more space must be created in order to alleviate those symptoms. These bulging discs or disc herniations can be incredibly painful, especially when that nerve is being impinged. But usually, individuals only realize that they have a herniated disc if this actually happens. There may be slight herniations that occurs throughout the spinal cord, and we may not realize it because the nerve is relatively unaffected. However, once a herniated or slipped disc begins to compress that nerve, neuropathy symptoms can be realized not only in the site where it's being impinged, but also can be referred to other areas of the body. For example, a disc herniation in the cervical region may cause numbness and weakness and other neuropathy type sensations in our upper extremity. And disc herniations realized in the lumbar region can send those same tingling, numbness sensations down either one or both legs. So these intervertebral disc sites are also considered joints of the vertebral column, and it's mainly there to absorb shock whenever we ambulate. Now for the joint site that really helps us move, this would be our facet joints. Each of the facet articulation is made from the inferior articulating surfaces of one vertebral body, essentially articulating with the anterior facet articulating joint of the descending vertebral bone. Each of these facet joints has a synovial joint capsule and cavity, very similar to what we see in our other diarthroidal joints in our body. These would be categorized as our gliding joints, and it gives our spine a relative amount of freedom whenever we do engage in spinal rotation, flexion, extension, etc. So just to recap, our facet joints are the joint sites that help our spinal column move, and our intervertebral joint site, more specifically our intervertebral discs, help with shock absorption. Now, other characteristics that we see in various portions of our spinal cord will be articulated in the next couple slides. So for our cervical region, again, we have 7 vertebral bodies that make up our cervical spine, and each of these bodies will have a bifiid spinous process. Bifiid just means that we have 2 heads that essentially come together and make up the spinous process. Once we go down from C1, C2, C3, etc., these bifiid spinous processes are rather small. But once we get to C7, the spinous process is actually pretty prominent and pronounced. And you can actually feel that right at the level of the top of the shoulder blade. Another unique characteristics that we see in the cervical spinal vertebral bodies is our transverse foramen. The foramen just means a canal or opening. And these transverse foramen are where the vertebral artery and veins will come through and give blood supply to the superior portion of the spinal cord. The vertebral artery will also give blood supply to the posterior portion of the brain, most notably our cerebellum, or at least parts of the cerebellum. And the vertebral artery will also anastomose or join together with the internal carotid arteries, which supply the remaining portions of our brain. TMI for this course, but it's good for you all to know. For our thoracic spine, again, we have 12 vertebral bones that make up the thoracic portion of our spine. This is important because we have our ribs that actually articulate with these vertebral bodies. The rib attachment sites will be on the costal facet surfaces of the transverse processes of the vertebral bones about the thoracic spine. And these articulating sites will be very similar to what we see in our regular facet joints, in which this is a synovial gliding joint site. Another characteristic here about the thoracic region is that we have typically larger and more vertical spinous processes. And these are the ones that we typically feel whenever we engage in lumbar flexion or going down, touching our toes, etc. So for our 12 thoracic vertebrae, we have 12 pairs of ribs and 24 ribs total. 7 of the 12 pair of ribs is what we categorize as true ribs. These are true ribs because they connect anteriorly directly to the sternum. The sternum is made of 3 different regions. I think it's better if I go back to the previous picture. The superior portion of the sternum will be our manubrium, and then we will have the body of the sternum, and then the small posterior portion would be our xiphoid process. So for our 7 true ribs, these ribs will directly connect with the sternum bone. The next 5 pair of ribs is what is categorized as false ribs. And these ribs either indirectly connect to the sternum or they don't connect at all. And they're essentially floating ribs. Getting more specifically with each individual rib, you notice that we have the head of the rib on the posterior aspect. And this head is actually the site in which it would articulate with the thoracic vertebra. As we move towards the anterior side, we will have the costal cartilage. And for the ribs that either directly or indirectly connect to the sternum, they do so via this costal cartilage. So our costal chondral joint site is the articulation between the ribs and the cartilage. And our chondral sternal joint site is where the costal cartilages of the first 7 ribs attach to the sternum. That's pretty much all I want you to know. We won't get into the specifics as far as the ligaments, but just know those basic characteristics for where the ribs attach, at which specific spinal column do they attach, and the fact that we have 7 true ribs that directly attach to the sternum and 5 false ribs that either indirectly or not at all attach to the sternum. It's also important here in this region that our ribs essentially protect more of our internal viscera that we see in the region. For the purpose of this class, this would be the muscles of respiration, I'll touch on this a little more at the end of the lecture, but just to give you an introduction, the main muscles that we see about the thoracic region will be our diaphragm and our external and internal intercostals. The sole job of these muscles are to help us breathe. Our diaphragm specifically is our chief respiratory muscle, and whenever the diaphragm contracts, we are inspiring or drawing air into the lungs. And whenever we expire or breathe out, the diaphragm will relax. Our external and internal intercostal muscles will make up the spaces within the ribs. The external intercostal muscles will be the muscles on the most superficial aspect. And then once you get more deeply or deeper within the spaces of the ribs, you'll begin to see your internal intercostal muscles and eventually our innermost. Our external intercostal muscles essentially draw the ribs up, so it aids in our ability to inspire or draw air to the lungs. Our internal intercostal muscles helps us breathe out. Now for our lumbar spine, again, these are numbered 1 through 5, and this will be our largest vertebra from a cross-sectional as well as a girth standpoint, if you will. And this is necessary because as we go down the spinal cord, more weight is needed to be supported. And with that, our lumbar spine region is definitely important for weight bearing. What you will also notice about the lumbar vertebra is that the articular facet surfaces are more vertical instead of more of a diagonal direction like we see in our cervical and our thoracic region. Unsurprisingly, the largest vertebra will be our L5. Our L5 is also important for the articulation with the sacrum via its inferior articular facets. So just to recap on the specific characteristics that we see within each vertebral region for our cervical vertebra, this will be our smallest, and this makes sense. It allows for more range of motion, along with the bifiid spinal processes that we see. We also have our transverse process, and within those transverse processes, we will have our transverse foramen. This is where our vertebral artery and veins pass through on its way to our anterior spinal cord and posterior brain regions. For our thoracic vertebra, not only do we have particular facet joints that allows for the articulation of the superior and inferior vertebral bones, we also have the facet articulations that allow for the ribs to attach. Again, 12 pair of ribs for 12 vertebral bones, and you have the transverse processes of these thoracic vertebral regions more pronounced and protruding more vertically. And lastly, we have our lumbar region. This will be where our largest vertebra is housed, mainly due to its responsibility to weight bear, and L5 specifically will connect the last of the free articulating vertebra to the fused vertebra in our sacral region. So for the ligaments of the spine, we have our anterior and posterior longitudinal ligaments. You notice that the anterior longitudinal ligament is larger compared to the posterior longitudinal ligament. And this will also explain why whenever we have our disc herniations, that the nucleus propulsus will actually protrude more on the posterior side. Like we have more protection on the anterior aspect of our vertebral column via the larger anterior longitudinal ligament. The smaller posterior longitudinal ligament, although it does help with keeping those discs in place, it's more easily displaced whenever we do have the disc herniations. We have our ligamentum flavum, and this is just between the lamina of each of the articulating vertebra. We have our interspinous ligaments, which connects the spinous processes, more so on the medial aspect. And lastly, we have our supraspinous ligament, which is located between the tips of the spinous processes. Pretty much straightforward on the ligaments. These play an important structure in holding the vertebral column in place, especially when we move. Outside from that, it's relatively cut and dry. For our sacral region, this is essentially an irregular bone that is made from 5 fused vertebral segments. The sacral bone's articulation with L5 will occur about the superior articular facet regions, and it mainly serves as not only a base for our vertebral column, but also for various muscle attachment sites, both on the anterior and posterior aspect. Also remember the all-important sacroiliac joints, which involves stabilizing pelvic regions during rotational and translational movements. And it's incredibly important for that transfer of force, especially when we engage in weight-bearing activities. Okay, so for spinal movements, an important note here to consider is that most movement occurs in the cervical and lumbar region. Although we see some slight movement occurring in the thoracic region, we don't want that region to move so much, mainly because this is where our ribs attach, and our ribs provides that protection for structures such as our heart, lungs, etc. But for our spinal movements, the actual spinal column movements will occur either in the cervical or the lumbar region. More specifically, movements of the head will occur between the cranium and our atlas, as well as other cervical vertebrae. And our trunk movements will mainly implicate our lumbar region and how it articulates with the thoracic region. Again, for this, just know that our cervical and our lumbar region is where most, if not all, of our spinal movements are realized. So for spinal flexion, this will be the anterior movement of our spine, both in the cervical and the lumbar region. For spinal extension, this will be either the return from a spinal flex position, or it will just be the posterior movement from our spine, either away from our chest in the cervical region or away from our pelvis in the trunk region. We also have lateral flexion and lateral rotation occurring about the spinal region, and all of those movements are seen in the images below. So because we are dealing with the spinal column and the trunk as a whole, we will be considering a lot of muscles that has multiple segments. What this means is that there will be a large muscle group, and depending on where it's located within the spinal region or within the abdominal region, the muscle will be named more specifically towards that region. For the purpose of this class, I'm just going to require you to pay attention to the muscle as a whole and just understand that there are multiple segments. Many muscles of the trunk and spinal column do function to move the spine and also help with respiration. And as I mentioned previously, all thoracic muscles are primarily involved in respiration. When we get into our abdominal wall muscles, so our rectus abdominis, our external and our internal obliques, you'll notice that these muscles do not actually come from bone. So they don't have any specific insertion sites to any bony architecture, but they actually attach to a surrounding aponeurosis around the rectus abdominis muscle. So here we have a picture of a cross-sectional area. So imagine that you're laying face up and you have a frontal cross-sectional view. You notice that here we have our rectus abdominis muscles, and then we have our external, our internal, and our transverse abdominis. We'll go over these muscles shortly, but I just want you to notice that the attachment sites of these muscles are essentially through the aponeurosis of the anterior lateral abdominal wall. Now, the aponeurosis is actually anchored on the posterior aspect of our body, but on the anterior aspect, these actual muscles are only attached via the anterior lateral aponeurosis. Okay, starting from the muscles of the vertebral column, we will really only consider one main muscle, and this will be our erectus spinae. The erectus spinae has multiple segments, so not only from a capitis, a cervicis, a thoracis, and a lumborum aspect, and that simply means that The erector spinae muscle covers essentially the whole portion of the vertebral column. There's also specific rows that we have that make up the erector spinae muscle. The most lateral row would be our iliocostalis. The middle row would be our longissimus. And the row that is most medial and closest to at least the spinal processes of the vertebral column will be our erector spinae spinalis. So our erector spinae muscles are made up of those three longitudinal rows, and each of these rows will cover the capitis or the head region, the cervicis or the neck region, the thoracic or the thorax region, and the lumborum or the lumbar region. So this muscle group as a whole not only extends the spine, but is also responsible for lateral flexion. So for the purpose and scope of this course, especially on the posterior aspect, just know that we do have this large band of muscle known as the erector spinae, and it's responsible for spinal extension and lateral flexion. We also have our splenius cervicis here. If you all would remember in the head and neck lecture, I spoke briefly on the splenius capitis and the splenius cervicis muscles. The splenius cervicis muscle is the muscle that will mainly act on the posterior neck region, and it's mainly responsible for that spinal or cervical extension action. Lateral flexion of the neck will also be realized about the splenius cervicis. And as far as everything else down our vertebral column, especially on the posterior aspect, the main muscle of note here will be our erector spinae muscle. Now for the muscles of the abdominal wall and our lumbar region, we will primarily focus on our abdominis muscle group, as well as our quadratus lumborum muscle on the posterior aspect. I'm sure you all are pretty familiar with the rectus abdominis muscle. This is our six-pack characteristic muscle, so the muscles that you see whenever you see a six-pack. And this will be located on the more anterior aspect of our abdominal wall. Because of its location, whenever these muscles contract, it will cause flexion about the lumbar region. Another important note here, whenever we're considering actions about the abdominis muscle group, the corresponding vertebral action will be the lumbar region. Remember that movements about the vertebral column mainly occurs within the cervical and lumbar regions, and not so much the thoracic region. Our external obliques will be located on the anterior lateral aspect of our abdominal wall, and these fibers actually interdigitate with our serratus anterior muscle. Remember, that's a muscle that moves that shoulder girdle. And how the external oblique fibers run, they run in a diagonal direction, very similar to how your fingers will be oriented whenever you reach into your pocket. If you reach into your right pocket right now, the direction of how your fingers are oriented is roughly how the fibers of the external oblique run. And because it's located on the anterior lateral compartment, not only is it responsible for lumbar flexion, it's also responsible for lumbar lateral flexion, as well as lumbar rotation. Now, there's an important note here when we consider the external oblique muscles. Whenever they contract, particularly with the lumbar rotation action, it's going to result in the contralateral rotation movement. So specifically to our external obliques, if I activate my right external obliques, that will cause a left lumbar rotation movement and vice versa. So this is very similar to what we see in our cervical region when we talk about our SCM or our sternocleidomastoid muscle, and that it results in that contralateral rotation action. So our internal oblique abdominis, these are the fibers that run more deep compared to the external oblique muscles. And let me also mention that the muscles of the abdominal wall organized via layers. So the most superficial layer will be our rectus abdominis and our external obliques. As you begin to kind of peel away, the more deeper abdominal musculature will begin to surface, and the more superficial deep abdominis muscle will be our internal obliques, and their fibers will run a little more horizontally there may be a slight diagonal orientation. However, these orientation will run essentially in the opposite direction compared to the external oblique abdominal muscle. So for the external oblique, I told you these fibers will run as if you're putting your hands in your front pocket. The internal oblique abdominal muscle fibers will run as if you're putting your hands into your back pocket. And like the external obliques, contraction of the internal oblique muscles will cause lumbar flexion, lumbar lateral flexion, and lumbar rotation. However, the only difference between these two muscles is that the internal oblique abdominis is that if you contract one side, it will result in the ipsilateral rotation action. So if I contract my left internal oblique muscles, or the muscles that make up my left internal obliques, that will cause me to rotate to my left side. So once we go more deeper, we will have our transverse abdominis. And our transverse abdominis, how these fibers will run is essentially perpendicular. And although the transverse abdominis helps with the anterior lateral muscle movements, one of its main functions is to help with forced expiration whenever this muscle contracts. So as far as muscles that are primarily responsible with our ability to breathe, along with our diaphragm and our intercostal muscles, the transverse abdominis will also play their role in those functions. And on the posterior side, I did not include a picture. We have our quadratus lumborum. This would be our QL muscles, and this is located more so on the posterior inferior aspect of our vertebral column. Contraction of our QL muscles will result in lumbar extension. Because of its attachment site to our pelvic region, it also helps in stabilizing particular portions of our lumbar vertebral column as well. Last overall muscle group that I want to briefly touch on is the main muscles that help in respiration. As I mentioned previously, the chief muscle that is responsible for respiration will be our diaphragm, as well as our external and internal intercostal muscles. The muscles that are considered more secondary respiration muscles will be the transverse abdominis for one, as well as the muscles that are used to elevate the ribs during heavy breathing, especially. So these would be muscles such as our scalenes, our sternocleidomastoids, levator scapula, as well as other muscles here that I didn't really touch on. But either way, the primary muscle of respiration will be our diaphragm, as well as our intercostal muscles. And our secondary muscles would be more so the muscles used to elevate the ribs, as well as muscles in the abdominal wall region that are used especially during forced expiration. So when we talk about this idea of core, when we use the term core, this is essentially an umbrella term. So not only do we have to consider our lumbar pelvic region or our abdominal region, we also have very, very small muscles as well as muscle groups on the more deeper aspect of our trunk region that really aids in our ability to stabilize our core. So the intrinsic stabilization subsystem, if you will be comprised of one, our diaphragm, our transverse abdominis, our multifidus muscles, which is essentially just the muscles that actually attach to the spinous processes here. Very small muscle group. I'm not going to really harp too much on this. Our quadratus lumborum, as well as our pelvic floor. Now, along with the extrinsic muscles that help us stabilize our core, one can argue that the more important muscles that we should also consider is our intrinsic muscles. And what's often neglected in core training is the ability to address these specific muscles more adequately. Seeing that this is the more intrinsic muscle component, addressing these structures and muscles will be as important, if not more important, just to ensure that your core is adequately stabilized.